today we're dealing with patient experience, at least that's the title of the seminar. But on reflection, I wondered whether it was the right word. Patient experience has become something of a jargon term within the National Health Service, and it may be not entirely clear sometimes what people mean by it. So I picked out on that slide some of the things that it might mean. It might mean the direct experience that people have of care and treatment. It might and will be involve the observation of the care and treatment of others. The needs and expectations as expressed from the user of the service's point of view. It's of course not only about patients, it's about the wider community, carers, families and other supporters of patients. Also the public, not only as potential service users, but also as citizens. Just pausing there, how many phrases have I used apart from patient? I don't think the health service quite understands or knows whether it's dealing with somebody called a patient, a service user, or, dare I say it, a customer, which I don't personally like as a phrase. But all these phrases get used in different parts of the NHS, and we don't really know necessarily even who we're talking about the service serving. And then, of course, what is it all about? Well, it's about how do you involve all those people and that interest in the system and use that vast body of experience to inform how the service is provided, what service is provided, and to what standard. Clearly the NHS has had many different ways in the past of doing that. But it might be thought, certainly if anyone has listened to the evidence given to my 2 inquiries, that it hasn't succeeded so far in involving patients in a way which has really made a difference. I'm going to start, though, with something I've become quite fond of doing, which is quoting Florence Nightingale. Do you know, standards haven't changed hugely in terms of what they should be. They're really quite simple. Florence Nightingale was not the idealistic saint that many may now believe she was, but she wasn't even really entitled to the sole credit for the setting up of reasonably decent hospitals that she did. But she had many things to say about nursing, some of which, it seems to me, are as pertinent today as they were then. And one of them was what emphasis she placed on the feelings and needs and experiences of patients. This is an example. Apprehension, uncertainty, waiting, expectation, fear of surprise do a patient more harm than any exertion. Remember, he is face to face with his enemy all the time, internally wrestling with him, having long imaginary conversations with him. You're thinking, that's the nurse, of something else. Rid him of his adversary quickly is a first rule with the sick. That's a rather longer one, but what would she have said about what has been described on some wards in Stafford, when she said then, very few people, be they of what class they may, have any idea of the exquisite cleanliness required in the sick room. And then the next paragraph, the well have a curious habit of forgetting that what is to them but a trifling inconvenience to be patiently put up with is to the sick a source of suffering, delaying recovery, if not actually hastening death. And I could read on the rest if I had time. Attitude. She was quite strong on attitude. What can't be cured must be endured is the very worst and most dangerous maxim for a nurse which ever was made. Patience and resignation in her are but other words for carelessness or indifference, contemptible if in regard to herself, culpable if in regard to her sick. Who said nursing was complicated? Moving on to Lord Darzi, who perhaps puts these things in a different and more modern way. In High Quality for All, he set out a vision for future healthcare, and it's saying, with those principles. And one of them was the empowerment of patients. To him, empowering patients meant choice, better information, increased control, control over resources, and partnership focused on people. And what he meant by high quality care included those three concepts. One was, which Florence Nightingale, of course, espoused as well, and Hippocrates, we do no harm to patients. The other was patient experience, which was about the quality of caring, compassion, dignity, respect, which could only be improved, he said, by analysing and understanding patient satisfaction with their own experiences. And then the effectiveness of care was to be judged, importantly, you may think, from the patient's own perspective. Well, some of these things were translated into the NHS Constitution, which has a number of rights of patients and a number of pledges on the part of the National Health Service. The important thing, perhaps, to remember about the Constitution is that although it was published, I think, in 2010, it contained very few new rights. All the rights in it, or most of them, were taken from existing rights promulgated in other documents or other laws. So we had the right to be treated with dignity and respect, to make choices about care, to be involved in discussions and decisions about healthcare, and to be given information to enable that to happen, to be involved in the planning of healthcare services, and to have any complaint dealt with efficiently, to have it properly investigated, and to know the outcome of any investigation. There are some pledges there, the precise status of which is something perhaps I might need to explore, but not today. Some of those rights, I think, will become as a bit of a surprise to those who have been profoundly affected by what happened in Stafford. They are people who want to know not only why their relatives were allowed to suffer as they did, but they want the system changed to reflect that experience. And some of them, many of whom are here today, have sat through virtually every one of the 133 days of evidence to bring that point home. Patient experience comes in many forms. In the course of my first inquiry, sat, and some have criticised it, in a private room and listened for over a period of 3 weeks to approximately 3 families a day telling me about their experiences in Stafford Hospital. There is something about the power of words spoken directly face to face in a quiet room which has a greater impact than a Healthcare Commission report, figures about numbers of complaints, trends, quality measures, and so on. And I just ask you perhaps to reflect on 2 passages there which come out of my first report, which are directly what 2 very ordinary people, I may not be rude about them, I'm not being rude about them, but complimentary to them, how they eloquently put the experience that they observed and felt on the wards of Stafford Hospital. Coming on to the present inquiry, it continues. A person left in blood-stained clothes without being washed, who felt demeaned. He lost a lot of his dignity, his pride. And then asked the nurse, "Could you help my husband, please, to the toilet?" "Oh no," she says, "I can't do that. I'm looking after the 4 beds the other side." Another case, she'd been saying symptoms of diarrhea. She wasn't tested for C. diff. The fecal smear sample was left on her bed table amongst her drinking cups, and I had to call one of the nurses to take it. Another case, I was surprised they'd managed to come back so quickly from cleaning another patient. I noticed they're still wearing the same gloves. I had to tell a nurse to wash her bloody hands. Now, reading, I would have thought any one of those stories would tell you, if you believed, as I have, the account given, would tell you there's something very seriously wrong in the hospital that's providing that care. And indeed, that was the conclusion at one point, of a solicitor working in the trust who was asked to investigate the death of a patient who was insulin dependent and had not received insulin. A detailed investigation report was provided by him, and he came to those conclusions. But he also said that there were several systemic failures and issues which caused the SUI to occur. Unfortunately, it cannot be said that these failures are an isolated incident and unlikely to reoccur. That report didn't find its way into the hands of the family for a very considerable period of time. The SUI was reported to, but not digested by, the Strategic Health Authority, and nothing really happened until this inquiry took place. So, complaining. Well, I've heard lots of evidence about the experience of complaining. So this lady was asked to meet someone in a room which she thought was a broom cupboard, and she came away with the, rightly or wrongly, with the experience that they just wanted to get rid of her. The effect of complaining can be to produce utter hopelessness and a feeling that nothing you say or do will make the slightest difference. And I don't think that those who participate in this process always quite understand the impact that bad complaint systems have on individuals who become injured, and I mean injured, and damaged by a process which should heal and put things right. The letters I received from up and down the country, and I suspect Julie Bailey will confirm this from her experience, tell me that there is a vast number of people in this country who feel not only aggrieved, but physically hurt by the way in which they've been dealt with and, in their view, rejected. Now, I can't believe that that's been the intention of either those who set up the system or indeed the vast majority of those who operate it. But that has actually, it seems to be, been the effect. And then one comes to the endless battle. You never get the right answer. You never get a full answer. So you carry on and on. And of course, the longer you go on, the less chance there is of you being able to put to rest all those feelings which come with loss. Unfortunately, things, it would appear, don't get any better. One of the questions I'm often asked, and many people here are asked, is with Stafford an isolated case? Well, last week, hot off the press, the CQC report about Barking and Havering, and we have evidence accepted by the Care Quality Commission which could have come straight out of my first report about the events in Stafford, albeit in an entirely different midwifery context. Someone who had to tell a consultant who was late coming to put in an epidural to stop laughing, and a midwife telling another patient, hurry up, that's to deliver, or I'll cut you. So where are we today? Well, the people who have been sitting through 133 days of this inquiry want things to change. They have taken on themselves a very considerable burden in continuing to relive experiences that I'm sure many of them would rather put away in order to improve things not just in Stafford, but also elsewhere. And what I would like to hear from people today is a contribution not really to what has gone wrong in the past. I think maybe that is pretty clear. But what can be done for the future? I'm particularly interested, if I may, to hear views on how the new organisations that are being set up or have already been set up, like Health Watch, Foundation Trust Governors, Overview and Scrutiny Committees, can be used by patients and the public better than those similar organisations have been in the past to ensure that change takes place and standards are maintained and improved. I would like to hear from you about how complaints, incident reports and so on, and other forms of feedback can be used better than they are at the moment. I would like to know how it can be ensured that patient and public views and experience can be made to have an impact, and a better impact, not only locally, but also regionally and nationally. How is it that we keep the sort of experiences that I put up on those slides in front of and in the awareness of all those who make the decisions that actually end up, albeit unintentionally, with that result, so that they stop thinking about just about numbers, as I said in my first report, but start thinking about people as individuals and as individuals rather than just as problems. And how do we instill the principle of no decision about me without me, which is said to underpin NHS reforms? How can that be made a reality? And finally, but by no means least, I'd like to hear some views, if I may, on the particular needs of the elderly, both in terms of involvement and representation of them in their care, but also in the wider context. Is there something special that needs to be done about what now appears to be the vast majority of patients who go through our hospitals and the care that they receive? I've spoken for too long, but it's my privilege as chairman. I'm grateful, very grateful to the speakers you're going to hear today, who've come at very short notice to help me, and I hope help you in formulating some of the ideas that I hope to hear from you. But thank you very much for coming today, and I very much look forward to hearing what you have to say.